Good. So let's just bring this up. So apart from welcoming the SPRs, we're also welcoming some local GPs, we're welcoming people from public health, we're welcoming some directors of public health for the high incidence boroughs. So, because the idea of this on World TB Day is just to show how when you actually become a consultant, you have to work with all these different agencies, and it's only when you do work together that all these things actually produce a result. So I was going to talk a bit about TB in Hackney. And there are just a couple of things, more for the DPHs hopefully than the SPRs, but about TB. So TB is spread by coughing. And although people have said, oh yes, London's the TB capital of Europe, which it is in terms of notifications, you have to remember that, for instance, in Denmark, they won't get notified if they're not culture positive. So quite a lot of our TB is extrapulmonary disease. And what we need to know is that it's spread by smear positive disease. And that's why it's a bit disappointing that we only had the published data for smear positive TB from 2006 to 2010, because those are the things that actually show what we're doing. And then again, symptoms of TB, this is just to remind you, just in case you feel a bit, we have a cough during the clinic. But TB used to be an occupational disease of physicians, but it's clear that none of the symptoms are that specific, and that's why the diagnosis is delayed. So we talked about infectiousness. Actually, TB is quite a difficult disease to deal with in the sense that it's not so much to deal with, but in terms of transmission, because you need close household contact. You need a fairly long time, and particularly more than 8 hours. And what we've noticed that even though we have a lot of TB, that it tends to stay in the communities which originally brought it. It's not like flu, which would spread throughout the whole of London. And I think those are useful things to think about when we come to the next bit. So, as you can see, this is a map of the world, and the darker the colour, the more TB there is, and Greenland is probably the highest in Europe, and apart from Moldova. But you can see that sub-Saharan Africa and India and Southeast Asia are very high incidence areas. And for the same year, if we look at the percentages, we can see that we've had people in Hackney from practically every blue area that there is in terms of numbers. And if we look at places over the last 10 years where we've had people with TB from, which are the red dots instead of the percentages, you can see that there are not many countries that we haven't had, apart from Australia. Sometimes it's a bit difficult to grasp about how big a problem TB is, and so you want something that relates to not just incidence, so the colours, so the Congo is particularly dark, but in terms of population, you can see that India, China, and Africa obviously not only have a lot of TB, but they also have quite a reasonable risk of TB. And when you put it that way, then you can see the risk of TB compared to Hackney, and you can see that both India and Nigeria are contributing quite a lot to our local TB. And then Vietnam comes next. So why do they come here? Why do they come to Hackney? It's partly because we used to have cheap housing, and also other boroughs like to lodge all their new entrants in Hackney, particularly Westminster. Sorry, it's the DPH from Westminster here. But also that these areas have been conflict zones. And we used to say that whenever we saw a group of people arrive with TB, we could almost guarantee that there was some conflict going on. But in fact, if you look at all these in terms of personal violence, in terms of terrorism, in terms of general wealth, in terms of food security, they all highlight those same sort of areas. So it's not surprising people come to the UK. to escape from all these things. One of the things we noticed over the past few years is that there was a general rise in TB across in London during this period. So what we've done is try to look at two boroughs that are close together and just see if there are any differences with what actually happened. So you can see that they're all lined up. The black line is London overall, and this is Newham, this is Hackney. And you can see they're all lined up for the first few years. And then we just followed the same sort of rates. And you can see that as time went on, there was a big separation between these. I've also put the local incidence in terms of population, but the problem, as we knew when we got the 2011 census, was that actually all the population estimates were not that good, and Newham suddenly had another 50,000 people more than expected. The other thing about the notifications is that you can see this levelling off, but there has been a change in how people are notified, so that if they're not a London resident, then they don't appear in the figures. So that means homeless people don't appear in the figures. Also, if they say that they live somewhere else outside London, then they don't appear. Whereas what's important is the actual number of cases and your locality. So, standard Stop TB strategy. These are the sort of basics that people actually have to want to do something about it. You've got to be able to diagnose the TB. You've got to have standard treatment. You've got to have drug supply, and then you've got to see what you've done. So if we look at that, you can clearly see the moment the political commitment set in terms of just having the patient-to-nurse ratio. So this was specified by the London TB Group in 2000. But until there was the political commitment, the ratio varied quite a lot until suddenly in 2005 we had 1 per 40. And then also we were saying that in terms of hard to reach, down here, that we aimed at 1 to 10, and I noticed the new figure saying 1 to 20 is fine, but if it takes you half a day to actually go and deliver DOT to somebody, then you're going to need a lot of manpower to do that. So, case detection. First of all, it's all about risk. What do you think? Oops, what's happened to you? This thing has just gone off. No, it's gone to video. Oh, here we are. Thank you. Right, so you want to look at the populations that you think are likely. So if you look at the population of Hackney, done by the different groups, so you can see the white, African, Afro-Caribbean, and then you're coming to Indian subcontinent here, you can see that there are higher groups, particularly in the African and the Indian subcontinent. But others, curiously like the Afro-Caribbean population, is exactly the same proportion as you'd expect if there was a general risk. There are some oddities which I've highlighted. Here we've got the 2011 census for Somalis, and it looks as though 1 in 6 Somalis actually has TB. But clearly that's how the census information was collected, and they didn't identify themselves as Black/Somali. So, apart from thinking about the risk, you want to send sputum early, which is we started sending letters out to GPs in 1997 if they thought it might have been TB. We started new entrant screen in 98, GP screen in 2003. We had direct radiology referrals from 2004. And finally, managed to persuade the surgeons that they should culture lymph node TB in 2006. And then we also had lots of material where people weren't suspecting TB, that then proved to have TB. So after a case of, quote, Crohn's in an Indian who didn't do very well on steroids, we then asked for some direct histological referrals.